So my name is Angela Tang. I'm part of the Lotus project. I'm also part of RAMS. We're a nonprofit agency in San Francisco. I get to have the privilege of being on the stage or panel with these wonderful, inspirational speakers today. Each of them, for the next a little bit over an hour, we're talking about the barriers to accessing mental health. And then later on in the day, you'll see that we talked about how we can build allyship and other type of pieces around how we can build upon the foundation from this morning and then also this panel. Each of the presenters will say a bit more about their background, but if I could just say that Annie Liu on this side, she's an associate marriage family therapist. She's from RAMS. Then we have Dr. Michele Wu and Dr. Bandy Loth from AACI, which is in San Jose. And then we have Sonnara Sen from CERI, which is in the East Bay. So without further ado, and then we'll have a couple of panel questions that I have proposed, and then we'll take a couple of questions from the audience, so you can start kind of thinking about what are some of the questions you'd like to pose. Okay.
Hi, can you all hear me?
Yes.
Yes, my name is Annie, and just to tell you a little bit about myself, I consider myself a 1.5 generation immigrant. I was actually born in Venezuela, so I spent part of my childhood in South America. Then I was separated from my family of origin and was sent to Hong Kong to live with another family for a year, and then we were reunited. And we immigrated to America when I was about 10. And I became a physical therapist for almost 30 years, primarily working with Asian American communities. And it was there that it really opened my eyes to the suffering of many Asian American community and their families. The stories that were told to me reveal a lot of pain, and they suffer much more than they needed to, I believe, because they didn't seek mental health services. And the latter part of my work with Asian American in physical therapy revealed a lot of barriers that they had to navigate, as well as my personal stories of both my parents having suffered trauma, as well as passing on, I believe, some of that trauma to me and my families. It really drove me to this later second career as I am now, doing mental health services the last few years with youth. So as a physical therapist, I work with the older population, and now my experiences are with the younger folks. But I'm really excited to be here with you all. Especially excited for the free lunch later. I thought it'd be important to go over some of the demographics of the Asian community that were the fastest growing racial group during year 2000 to year 2019. We grew 81%, from about 10 million to 18 million. Is that by 2055, we're projected to become the largest immigrant group, surpassing Hispanic. And by 2060, we're projected to be at 35.8 million people. And much of this growth will be projected to be in the school-age population. So by 2060, of 10 children is to be Asian. This is important to note because we want to know and address the needs. We're extremely diverse, over more than 20 subgroups. As you can see here, we come from different origin backgrounds and different languages, different customs. Especially now in America, we're not a monolithic group. We vary in education, in poverty rates, as well as in education, faith, immigration wave, immigration status. People often think of Asian American coming in legally, but that is not the story. Me, myself, and our family, we didn't come through the right way. This is what I've seen in physical therapy too. I work with hundreds and thousands of patients, and language proficiency was really a big barrier. And we know that it is related to income, related to occupational mobility. It is related to how well they can access healthcare, as well as how they can access quality healthcare. When I was growing up, I was an interpreter for my parents at 10 years old, and I don't think I was mature at that time and had enough understanding. And I could see how people were not getting the needs or treatment that they needed, and things were underreported, things were utilized because of the language. And household linguistically isolated means, under the US Census, it means that nobody age of 14 or over can speak English well or very well. This is our mental health engagement. 37% of Asian American adults, that's about 7.7 million people, reported poor mental health. We are the least likely group to seek mental health services, 3 times less likely than white counterparts. Of the adults with mental health illnesses, 73.1% did not receive treatment compared to 56.7% of the overall population. So we can see that there's disparity there. And I just want to touch on Asian American mental health for adolescent. Even within the Asian American community, I think people are shocked to see that suicide is a leading cause for young adults ages 15 to 25 because of the model minority myth. And girls in high school is 20% more likely to attempt suicide compared to non-Hispanic whites. Major depressive disorder is one of the highest in Asian American, particularly female adolescent. So in my work in physical therapy, I did a lot of home care setting visits where actually people did tell me the story because they felt safe in their own home. And we would see I would see a lot of depression. I wasn't trained at that time. I would refer them to maybe outside mental health services, but they wouldn't go. So the need was actually going into their homes. Another thing about Asian American youth is that they're at the greater risk of internalizing behavior. And so I work at the Wellness Center in one of the public schools here, and so we would get referral a lot for externalizing behavior of youth. So they would get referred because they were maybe throwing a chair in the classroom, they were angry and aggressive, a lot of mood dysregulation. But the Asian Americans were not referred as much because they tended to have more suicidal thoughts or depression, anxiety, or like they come in for headaches and stomach aches, and that's like a mask for dyslogical distress. And that's what I saw with a lot of my patients as well. Lots of complaints, but it was clear for any medical cause. I tend to talk a lot, so I'm not going to go through this slide, but these are some of the barriers. I'm just going to address 2 of the things, which is shame and fawning. Okay, so salience of shame in Asian Americans. We experience shame differently than other groups. So for us, we are going to experience shame in an interpersonal way versus maybe the white people experience shame internally. Like they view themselves a certain way, and they feel shame, meaning like they feel unworthy, defective, small. But we feel it interpersonally. So it's in the construct is actually 2 dimensions. The first one is external shame, I'll see this a lot with my work with the kids because they'll come in because somebody bullied them. They make fun of their Asian names. They make fun of their accent. So they become paralyzed, immobilized, feeling small and powerless. And that's associated more with depression, with depressive symptoms. So we see that. And we also see that as a white supremacy shame, right? White supremacy is we are supreme, we are superior. So they can marginalize a community just by shaming them into silence. And that could be, I've seen that with my students, but they don't have a way of figuring it out that is actually a society shame. The second thing is family shame. So that's being viewed by bringing the shame into multiple people, that there's consequences to the family. So for example, I'll modify some of the details, but an Asian American student was pregnant and she was feeling a lot of suicidality because she was bringing shame to the family. And her sister actually became very, very depressed because her sister viewed the shame as a failure on her part. And that is associated more with suicide because they want to avoid the pain of shame. And you can see how, because these incidents of shame makes a person avoid asking for help, thus they don't come to get services, right? It makes sense. And if you're wanting to hide and you want to avoid pain, you're not going to seek help. And also we mask that with self-sufficiency, to mask the low self-esteem, to mask the shame. So you see a lot of like really being productive, trying to do really well in school, try to get A's to mask the shame. Yeah, I just wanted to share something personal. I know that I have a little bit of an accent, and so this is, I've been made fun of about my shame, and so I spent many a times when Google exists, later on when the internet was available, is to actually, I practice certain words, how to pronounce it, and that's actually part of the societal shame, right? Shaming you for having an accent. And so it could immobilize a person. I'm gonna skip this. And okay, so we're very familiar with the fight, flight, flee response to trauma. And this is a fourth possible response, which is called fanning, right? And so sometimes we think fawning is a cultural response. We're quiet, we're people pleaser, or we can think of it as part of our personality. But I want us to think of it as maybe it could be considered as a possible response to trauma and a possible response to racial stress, racial trauma. So this is when we people please. This is when we have appeasing behaviors. This is when we want to establish safety. So we feel a threat. This started by, it was coined by Peter Walker. And so, for example, if you were in an abusive home and you're a child, you're not going to be able to do the fight, flight, flee, really. It would escalate the danger. And freezing is not going to help protect you. So we have adopted this fawning response for many of us. And that is to do and assimilate with the white culture. Is to reject our identity, reject our culture, our names, and maybe our language. We don't want to speak our language in public. It is to merge with the white people's wishes, their demands, and we have lost the ability of healthy boundaries. So we forfeit our rights. So when we forfeit our right, we forfeit our voices, and that way we are not getting the services that we need. And how is that relating to especially with this model minority myth. How many of you know about model minority myth? I don't want to, okay, so most people. So it's a very harmful message and it's not true. But what I see showing up in my work with my patient as well as the students is that this is one of the manifestations for farming. And this is how we internalized it, by believing the myth, right? So my father for the longest time was telling me, we're Chinese, we're hardworking, we're better than other people. And as I worked with a lot of my patients, we saw that not everybody was successful, not everybody was educated, not everybody was doing well. So this is the way we internalize this to keep us safe. So what we do is we strive to be closer to whiteness in order to be safe. We put our head down, we don't want to be a target, we want to be model minority to be closer to whiteness. And then we lose our ability to really know our feelings, to know our boundaries, to know what we want, and to know what we need. So a lot of my work with my students, they don't know what they want. They don't know who they are. They're just people pleasing. And a personal story I want to share. This happened to me just recently. We just got back from my nephew's medical school graduation just last week. We're in an elevator. We walk in. There's 7 of us, just my family. We walk in the elevator, and there's 2 people standing there. We were making a little bit noise because we were really happy that he was graduating, and one of the person rolled their eyes back, signaling that they were very unhappy with us being in the room. And my first reaction was to make him feel better, to sacrifice my own needs, to sacrifice my own feelings, right, to make him more comfortable. This is my fawning, I think, as I was kind of thinking about why did I have that reaction. And then I said to them, I said, oh, we're celebrating my nephew's medical school graduation, because I wanted to show them that I was closer to them. I'm a model minority. I could be safe now. I'm not going to be a target. Then I left thinking, why did I do that? We were just having a good time, and I felt like I had to apologize for that event. So I thought that was kind of correlated to what I'm talking about today. I just wanted so those are the 2 things I want to talk about that were the barriers to Asian American accessing mental health. But I also think it's important that I leave you all with some resources. This is on my slide. There's a lot of things here that you can access. And also, the cool thing now is, I don't have Instagram, but I'm sure all of you do. So this is, Asians do therapy. And then some reading list. You can't see it there, but the bottom, the quote I want to leave us with is that our world minimizes us and we minimize ourselves. And so I think this is very important as clinician to help our clients to be seen and not to minimize us and them. Thank you.
Hi everyone. So for my portion of the presentation, I will be addressing medication stigma and limited access to culturally competent care in the AAPI community. Let me do this one. So the goal of the presentation is to briefly discuss the cultural perspectives on mental health and medication, the stigma that is surrounding it, the impact of media, and the role of culturally competent care. So I also want to remind everyone that, this presentation is being recorded. Me being a student before, I like to write everything down. So please feel free to not feel be rushed about wanting to get everything from the slides. I also want to acknowledge that the topics I'll be addressing today, it's only going to be a snippet of it, right? Because in order to have a deeper discussion about it, it will require some more time, which I think will be part of the panel session later on. So let me just quickly introduce myself. So first, hi everyone, my name is Michele Wu, so I also go by Dr. Wu. I am a San Francisco Bay Area native. I am a daughter of Chinese immigrant parents, and I'm trilingual as I speak Shanghainese, Mandarin, and English. I'm the first within my family to obtain a doctorate degree, so I received my degree in clinical psychology at the California School of Professional Psychology at Alliant. And currently I am a psychological associate and behavioral health counselor at AACI, known as Asian American Community Involvement. At AACI, we are a nonprofit agency serving the Santa Clara County that offers mental health and wellness services that are based on whole person centered care with values of equity, cultural sensitivity, integrity, and excellence. So as mental health professionals, we've been entrusted with this kind of vital position or role to understand and address mental health issues within a diverse population, right? So today I really want to highlight, the spotlight is on the unique struggles and experiences of the Asian American Pacific Islander or AAPI community that often really grapples with cultural attitudes that can really complicate mental health. Especially, it can also create barriers to mental health. So historically, when you think about AAPI culture, it places a high value on stoicism, resilience, self-sacrifice, and they often view mental health struggles as either a personal or a family weakness, rather than it being a legitimate medical condition. So stigma around this can be incredibly difficult for people within our community to reach out and openly discuss their struggles. I know for me, growing up, mental health or let alone talk about emotions was definitely not common. I've often gotten statements from my parents telling me to basically tough it out. Stay quiet, don't need to, don't need to overly stand out, and just demonstrate that you're hard work. So with these type of messages, when we think about the model minority myth that we've been mentioning throughout our presentations today, this stereotype really suggests us that all people within the AAPI community are universally successful, or that we're all immune to social or emotional struggles which can really further intensify these issues. So this misguided perception can not only invalidate our experiences, but of those struggling with mental health issues, but also deter them from getting the need that they much need. So let's talk about medication. Sorry, I went too far. There you go. All right, so the cultural perspective that I just discussed really does contribute to the widespread stigma around psychotropic medication. So I've had firsthand how stigma can impact and be a barrier to mental health. So I remember talking to many clients, and there's this fear or judgment that they may have from friends or families. And so one particular story that kind of comes to mind is this one client saying, you know, I can't take my medication in front of my parents because one, they don't know I have mental health concerns, and two, I'm taking medication for mental health concerns. And so when they do go travel with their family, they don't take their medication, which really impacts the consistency or the effectiveness of the medication. So I also do work with a lot of Mandarin-speaking older adults, and a lot of their beliefs that they've shared with me is that, you know, medication is for really like extreme or severe cases, and that it's for people that are crazy, right? And that really contributes to that further stigmatization. I think what I've also learned from many of the clients that I've worked with is, you know, there are common concerns about potential side effects, long-term impacts of medication, especially when you think about addiction or dependency. And I also think the most common thing I hear is how if you do take a medication, it kind of numbs you out, or that it kind of changes your personality. And so on my PowerPoint up here, I do have a few statements that clients have said to me. And I think this fear can really cause some individuals to reject medication as a possible treatment. But I also want to acknowledge that, you know, traditional health beliefs and practices do play a significant role within many of our AAPI communities. And so because of that, there might be a preference for traditional remedies over Western medication. And that, you know, what I've heard too is that Western medication can be too aggressive or it's not as compatible. And I think one thing that I do hear, and also from other behavioral health counselors that they told me, is that clients often will say, oh, you know, when it comes to mental health, I can overcome it with willpower, and that I don't really need medication to help support that, right? And that kind of continues to add that extra layer of barrier. And so at AAPI, the behavioral counselors there, we are very lucky to be able to participate in client psychiatry appointments. And so we're able to provide that bridge of mental health and medication. But not only that, I think it's also really common to hear clients come into the psychiatry appointment talking about, I have sleep issues or any other kind of somatic symptom, right? Instead of maybe addressing, for example, depression. So I can see why I could feel a little bit more comfortable coming in talking about somatic symptoms like that instead of addressing, you know, mental health concerns, because it might just feel a little bit more socially acceptable, right? So I do want to talk about the impact of media. I'm not going to spend too much time on this, but when you think about media, you think about social media platforms, you think about films, you may be thinking about good news. And so when we think about those type of platforms, it does play a significant role in how it shapes, I think, most people's perceptions about that most people's perceptions and attitude towards mental health and communication. So on this PowerPoint, I've labeled a few key points, but I'm not sure if all of you do remember it. Let's think back all the way to 2004. The FDA had placed a black label on antidepressant medication, and at that time, the news was saying, hey, antidepressants are really kind of raising suicidal thoughts and behaviors within teens and young adults. And I vividly remember just, all over social media, the message I read from that was, hey, if you take antidepressants, that equals to suicide. And we know that is definitely not true, right? So a lot of this misinformation or oversimplification about mental health and medication can be extremely harmful. And I also want to say, when you think about popular movies like Fight Club or Beautiful Mind or the most recent movie, Split, all of these movies do portray main characters as unstable or overly sedated, or they're dangerous, right, and are not having a successful treatment. So I'm going to pose this question for you to think about on your own. Can you think of a movie that you've seen or heard the main character having a successful treatment, or even a fairly well-represented therapist? So let's move on to the next slide. So let's talk about the role of culturally competent care. So for this piece, I want to acknowledge that. It's really essential for us as mental health professionals to continue to educate ourselves about the diverse cultures, traditions, and values within the AAPI community, as well as really being open to learning from our clients and their personal beliefs and their experiences. I think more than just learning and understanding their beliefs, it's really important that we also validate their experiences and try to work with them within their cultural framework to provide effective treatment. So it may look like maybe incorporating those traditional beliefs into treatment plans or providing education on mental health and medication in a culturally sensitive way. And also remembering that when it comes to cultural humility, it isn't a checkbox, it is definitely a lifelong learning commitment as providers, but also as individuals. Definitely at AAPI, we aim to match clients to clinicians that speak their language. I think addressing language barrier is really, really important. Offering whether translation services who speak the language can really increase both accessibility and quality of care. And also wanting to acknowledge and address the stigma, right, that surrounds mental health within the AAPI community. I think the fact that everyone who is here learning and trying to normalize the conversation of mental health is what is going to help better us support clients, work with them, and also dispel myths. And also, especially in terms of dispelling myths about psychotropic medication. And I think perhaps the most important point, I think, for the role of culturally competent care is really striving to have increased representation within the mental health field. When clients are able to see providers that look like them and understand their culture and speak their language, that definitely does build a better trust and communication. So this doesn't mean just hiring more AAPI individuals within the mental health field, but it's also about promoting them to leadership opportunities in the field as well. All right, so my last slide. And so just to wrap it up, I think it's really clear that trying to tackle some of the issues that we've been talking about today really involves a comprehensive and empathetic and culturally sensitive approach. So together, we definitely can work towards a more inclusive mental health care system that really acknowledges the respect and the diversity of AAPI, the AAPI community. So with each step that we do take, it brings us closer to a system that where everybody, regardless of their culture, the cultural backgrounds, feels seen, heard, and understood. So, yeah, thank you.
At a loss for words, honestly, because we had really amazing speakers before me. I feel like I'm the newbie in all of this. My name is Sonnara Sen. I'm an MSW graduate, ASW right now, working towards becoming a clinician myself. I am 1.5 generation refugee. My parents are survivors of the genocide in Cambodia, and that's how I ended up here in America. So my story is one of struggle of, finding the healing for myself, like Dr. Jung mentioned earlier, to heal the community members that need the healing. And so I'm working currently at Center for Empowering Refugees and Immigrants as a therapist working with the genocide survivors from Cambodia, but we also work with refugees and immigrants from Nepal, Tibet, Burma, and most currently our newer folks are our Afghan community that are arriving right now. And so the work that we do is very boots on the ground, very meaningful trauma therapy, but then also dealing with the intergenerational trauma that the second and third generation are going through now. The barriers that I'm, seeing the trends especially during the pandemic. I I know Dr. Jung mentioned this also, was the data, right? And it's a big push, to disaggregate the data, because I know specifically in the Southeast Asian population, the Native Hawaiian, the Pacific Islander, it's difficult to lump us into one big number. I know during the pandemic, when we were looking for resources and trying to find language capacity, and the difficulty in trying to explain to them how to mask safely, how to isolate, where can you go. It's difficult because you don't have that capacity. There's no resources for it. There's no funding for it. And so how do we get this out to the community members that needed it the most? The ones that have pre-existing health conditions, that don't know what a pandemic is, that live in multi-generational homes, and they can't isolate properly. Right? So it was a very difficult thing to say, how do we get them the information about masking? How do we get them the information about vaccinating when we couldn't reach them? And there was not a place, because there was no central place for them to come to because of transportation barriers, language barriers. And so the other thing was technology, right? They were unable to access technology because they could barely speak English. How would they be able to do Zoom or learn of any of the campaigns that were happening, all the news stories that were in other languages than their own? Attitudes and stigma with mental health. I'm seeing generational differences with seeking help. Right now, I'm working specifically with the genocide survivors, and they're ready for the healing. They're open, they're wanting it, but we don't have the funding, the resources, or the capacity to deal with it, because my organization has been there for 20 years in Oakland, and I'm their first Khmer-speaking therapist. And so how do we get more people to step up to the plate to be able to provide that? How do we access those communities who are dealing with drugs, alcohol addiction, human trafficking? How do we empower them to, in turn, empower their own community? I'm seeing a need for more mental health access for our youth, especially coming from the pandemic and seeing that, when school went online for a year, had a major impact. At that time, I was working with high school youth, and seeing that there was not that culturally relevant therapist that could assist them in their needs was heartbreaking for me, because they didn't understand the amount of pressure, the cultural difference the parents were giving them, to succeed, even though they were isolated, even though they were unable to leave their house and be social, and all they had was electronics, right? Social media, all these things that are sending them these messages like, oh, I'm living this great life, oh, I'm doing all these great things, and I'm still traveling, and I'm able to. And so the impact that it's had on our youth, not only the generations before now, but the ones that are here, we don't have the resources. I remember specifically working with a high schooler who, we decided, okay, she needs psychiatric intervention, and we need her to get to see somebody, to get medication, to get more than I could provide. And just the hurdles as a provider myself to try to get this child help was crazy, because they were so impacted. They didn't have appointments. They couldn't even take the child in, and the hurdle of trying to find not only the child, the help they needed, the family that was supporting them, right? To try to explain in a different language what was happening with their child without, telling them too much about what was happening, and at the same time getting them to understand this child really needed it, right? So those are some of the barriers. Culturally appropriate care, understanding that there's many different religions, many different cultures, and there's many different languages. And so to just say that we're all just Asian, it's a very harmful thing. Funding and costs, Right now, that's my big push because we have funding right now and resources right now because the spotlight is on us because of anti-Asian hate. But anti-Asian hate didn't just start with the pandemic. Anti-Asian hate has existed long before the pandemic. And now that the pandemic has been declared over, what happens to that funding, you know? We've been able to utilize that funding now, but when that funding is saying, okay, well, the pandemic's over, you know, the crimes have slowed down a little, let's take away those resources and those fundings. Does that mean that our trauma has stopped? Does that mean that our healing is done? You know, so being there as advocates to push for that because it is such a needed resource in our communities. And the intergenerational trauma that I'm speaking of is, you know, in working with the elders that I work with now and seeing the impact of mental health with their children, dealing with drug addiction and gambling and alcoholism and homelessness and all these things that the elder are not able to care for, now has a third generation because they're left responsible for grandchildren, right? So they could hardly raise their own children because of their own trauma, and now it's skipped that generation because their trauma is so much and unable to deal with it that the traumatized grandparents are now traumatizing grandchildren. And so, like, what do we do about that? How do we change that? And this is just a little bit more about the barriers to mental health. Like I mentioned earlier, a lot of it is the data for the AA and HPI community, which is the new terminology now that has been thrown out there. Language access, I can't, you know, explain how beautiful it is to be a Khmer speaking provider and to work with Khmer speaking clients because it's something that's magical. Like the first day I walked in there, you know, they just lit up because not only am I Khmer speaking, I come from the same community as them. I grew up in Oakland. I went to Oakland Public Schools. These are aunties and uncles that I've known for forever. And so, you know, after I got that piece of paper, you know, from college and came back to the community and say, hey, like, it's me. Like, I'm gonna help you. I'm gonna be the one to help bridge some of these gaps for you. And just the warm welcome and the just, you know, openness of sharing, right? We get a lot of, oh, they're not ready to talk about it, they went through so much and all that. I haven't had that issue. I've sat there, I've cried with them, I've sat there, I've laughed with them. You know, sometimes we just play music and dance because, you know, sometimes the sorrow is too much. And so I'm looking at it from a culturally respectful way and letting them lead in what it is they want to heal from and letting them lead into how they want to heal from it. And so being respectful of the culture and the dynamics and hierarchy and the gender, honestly, because we run 3 separate groups for the women and then we have a separate group for the men. And there's a total difference in approach and care, just in that, you know? Even though we're from the same community, even though we speak the same language, there's a totally different approach. And so being able to have that eagle eye from the community has been very, very helpful. And then collaboration, right now I'm working with the California Stop the Hate project, and these are some of the things that we've come up with, you know, in California, which I'm really, really proud of, but this is specifically right now, mostly the Bay Area here. And I know we've worked with CERI is up there, that Center for Empowering Refugee and Immigrants, and I see my folks over there from Korean Community Center of the East Bay, VACSEP, which is the Vietnamese American Community Center of the East Bay, and then working with the Oakland Chinatown Chamber of Commerce, because a lot of the crime and, you know, the hate that's happening specifically in Chinatown and Little Saigon, a lot of the businesses that are affected there. I just connected with APILO, which is the API legal office that does pro bono work for our communities. So there's a lot of resources. And what we're working on right now is, and RAMS, a huge part right there, right? Big RAMS. A huge part of that is it's putting all these resources into a website. So that when we say as clinicians, who can I refer these folks to? You know, what other resources are available that can possibly help this person or this family? So it's a click away. Like, even though we've been working together and doing all this, there's not a centralized database for this yet. And like, why is that? It's been like several years now, but there's still not a centralized database for us to be able to say, okay, they need mental health, they need legal help, you know? So thank you very much. I appreciate it.
Thank you so much again for everyone's presentation. I get to have the honor to pose two questions, but we've also had the privilege of like being able to meet beforehand and have like conversations. And so there was two kind of things that kind of stood out in my mind that I wanted to pose. But I also want to recognize that all of you are from community-based organizations working in different, have your own lens in terms of school-based services or supporting those with providing medication support or kind of providing that background and being really in the community. From that, and there's a lot of, and each of you spoke about like the contributing factors of barriers to mental health access. So, and one of the things that I wanted to touch on was, how do you think the role of intergenerational trauma has affected our community? And also, like, from your own lens too, how is it specifically from the work that you do or the work that you've done that led up to this point? Whoever wants to kick us off.
Does this work? I'm not sure. I can say, speaking for myself, it's the impact has been very detrimental to my family itself. I'm the first in my generation, actually, including my cousins, to have a college degree, and that didn't come without struggle. I took 8 years to get my associate's degree at a community college because I was going to school during the day and working nights and paying my bills. But I just never gave up, and kept going. And, I've seen it play out in my own family where there's addiction, where there's homelessness, where there's mental health, and none of it is addressed, none of it is being helped, because when we arrived here in 1982, there was nothing here set in place for us, We arrived here, yes, but we couldn't speak the language. We didn't know the ways of America. There was nobody here that said, hey, let me show you the way and how you have to go about getting government assistance and all these things, I remember very specifically from my childhood, if you're Cambodian, about coining. And so I was a very sickly child, and my mom used to coin me, and so I'd have these marks. And I went to school one day, and the teacher called CPS. And so, they had a big CPS investigation opened up and stuff, and like, oh, she's being abused, she's got all these bruises all over her body. And so it has impacted my siblings in many ways. I know I have one who's like isolates all the time, and then I have one who deals with the depression, and sometimes she'll come out, sometimes she won't. I have one that's a total extrovert that like posts everything on social media, for the world to see. And so it's crazy to see that in my own family dynamic, but then also see it in the community that I serve. Because it's the same exact thing, but amplified, right, in the community, right? Dealing with, now we're seeing schizophrenia, bipolarism, And so all these things that have manifested and internalized that has been affecting the next generations. And it's not just mental health, it's really overall physical health. We're seeing higher rates of like thyroid issues, and I've noticed this in a lot of the Southeast Asian communities, and I would really like somebody to do some research on it because it affects so many people right now. I've met from Laos and Thailand and Nepal and Cambodia who all have thyroid issues, and the only thing I can think of they have in common is all this trauma that they've been internalizing, right? And it's had this physical effect on them. So I hope that answers all of that.
Hi everyone. I think in terms of AAPI, we're providing the perspective of medication support and what comes to mind in terms of intergenerational trauma. And I think it's just slowly happening now, but I know it's not the norm. But one positive aspect of it is at our agency, we were treating a Cambodian refugee female with PTSD or chronic PTSD, and she actually was able to recognize the anxiety within her adult child because she started noticing he stopped working, he started isolating, was no longer able to drive. He gave up going to the gym and had a difficult time just even interacting with the family. And she felt the need to connect him with AAPI. And I think that was only possible because her treating clinician was a Cambodian-speaking provider who was really integrated in the community as a strong leader already, and so there was that built trust. And her experience going through our clinic and feeling that she was able to receive positive help was a way that she encouraged her son to seek help with us. So within a few months, he's already was able to participate in Cambodian New Year's in Stockton at the big temple. That's a big deal in terms of the Cambodian community. He's interacting with his family again, and he's already making plans to slowly start leaving the house more and doing the things that he used to like. And so I think if the mother didn't have a good experience, that wouldn't have happened for the child to get treatment. I also see the other end happening too, that I think Dr. Wu highlighted about how mental health treatment usually is kept within, is like use your willpower and we'll get through this, we don't need medication. I think their parents' own delayed treatment in their own trauma ends up delaying treatment in the child's, whether it's some type of mental health condition with anxiety, trauma, or other things that I see both ends, that it either promotes treatment or it either delays treatment.
I think one thing I think for me is more of a personal experience, I think, and also from hearing from other clients, is especially with working with young adults, I think when they talk about their depression or anxiety with their parents, is oftentimes invalidated, because yes, we understand that our elders or parents have gone through specific traumas, especially if they're immigrants or refugees, but it doesn't mean that what we're experiencing currently is not valid, right? And so I think for me, being the first in my family, again, to get higher education, being able to start opening and having these really uncomfortable conversations really does make a difference.
Thank you for sharing. I also am thinking about how each of you in your journey, in your professional journey that came through here, and I want to acknowledge that everyone here we're a multidisciplinary panel here. And one of the things that I also took away from the amazing presentations is having that a provider that really understands the social context, the cultural context of the work. So I know that's one of the primary barriers to accessing mental health services. So what would be one of the primary strategies that you would recommend for, as for our system, or whether it's policy or maybe in our day-to-day, about how do we move forward in terms of having more providers who reflect our cultural diversity and understand the cultural context.
First and foremost is giving these communities access to education, equitable education, and then giving them opportunities that, with scholarships and grants to attain higher degrees. That's a huge part of it. And then at the same time, as providers, for myself in my community, I've seen that it's very resistant because their trust has been broken so many times. They've been hurt so many times by their own, by outsiders, by government. And so, growing up in Oakland, there would be programs that would be started, and then as soon as the funding went away, they just disappeared. And so that inconsistency and that breaking of that trust is ingrained in our communities too. So to acknowledge that hurt that has been caused already, and at the same time, providing a communal center where they can come and feel safe and get the resources, the language access to what they need. And this was posed earlier by an audience member of how do we change policy and how do we, access these communities is open up an AAPI community center. Let them utilize it. We can provide mental health resources there. We can have programs where we provide meditation and yoga and Tai Chi to the community members. They can utilize the space for cultural events and cultural holidays without stigmatization. And at the same time, they can feel safe in their community.
I think the question was how do we get more providers that represent the community. I think many of us probably can relate. I do come from a family with strong ties to work, so the idea of continuing school even for a master's or a doctorate just doesn't make sense in terms of you can get a job, you can work, why would you put yourself through those challenges? And I realize that oftentimes our parents or older generation don't have examples in terms of what success looks like for these folks that do have a master's or doctorate in the mental health field. I think in media you always see success as a doctor, success as a lawyer, but nobody really highlights a success as a mental health worker working in the community. So I think there's a lot of fear on that end, so there's not really a lot of support from the family side in terms of folks pursuing the mental health field. And I think us being here together and seeing the importance of it is a start, and I would hopefully encourage that you guys are the leading example for the next generation as well, is that this is something that is valuable. I think it's planting the seed, and I think we're in the growing pains phase where it isn't easy, but we'll make it easy for the next group. I like that the AACI itself is a big teaching facility. And so we do bring in folks to get that cultural piece, to be able to interact with a lot of our monolingual clients and understand stigma and how to address it in a different way. And so on my end, in terms of medication support, if your agency does provide psychiatry, I would highly encourage the agency to connect with different universities to even take on interns and students, because eventually they'll be able to take on what they learned and give back to the community as well. So I think that's my biggest recommendation, is either more visibility in terms of minorities pursuing mental health fields, as well as partnering with different universities to continue to teach the next generation.
Yeah, I just kind of want to add to Dr. Locke too. I mean, at AAPI, we do have our doctoral and master's internship opportunities, also for social workers and nurses. So having, I think, more agencies that provide these opportunities to train and to learn is really important. But I think also outreach, especially when I was younger at school, no one came to school and talked about mental health per day, right? So I think recently, especially at AAPI, we have a K-8 program where they go to schools and they talk about what mental health work looks like and what is mental health. So I think having that exposure early on really can be like a step forward to getting more people in the field.
I know we're getting to lunch, but which I'm looking forward to. But just a few minutes, a little bit more about just something practical I think we can do as a strategy is really just, for me, in working in school system, is to have support group. So right now we don't have a lot of providers with the needs. So basically having support group, and actually I talked with my wellness coordinator last week about starting an AAPI support group in the school where we can just talk about lived experiences for the students and the young people. The second thing I was going to mention is also a very simple thing to do is just to have a pamphlet or something in for families who don't speak English in multilingual languages to pass out, and in explaining mental health literacy, that maybe explaining depression is not just simply having a bad day. That kind of education would be helpful. Another thing would be helpful is I've been meeting with a lot of parents, and the way to do it actually is reframing the languages initially, is by not saying, oh, you better come in because your child is depressed or your child wants to kill themselves. But what I do is, oh, your child is having difficulty in school. Once they hear that, they want to come in, and then we can address other things as the conversation goes along. The other thing I wanted to mention is I really like the idea of having it, the services be in place in community center where people go, and because of my work with homebound patients, having maybe in the future having therapists, just like we have physical therapists, occupational therapists, speech therapists going to the home, we would also have mental health counseling therapists going into the home for homebound patients, as they are actually, I find, eager to tell their stories. I've heard very horrific stories of genocide, of people being thrown overboard as they're coming as both refugees. Personally, my father saw beheading. He was only 7 years old, and he saw 2 of his younger sister killed during the Japanese occupation. So he's never had a chance to process that, and so there's a lot of trauma within our family. So it's impacted us personally and even now. So anyway, I'm just really excited for what's to come, and I just want to thank you and have a great lunch.
Thank you, everyone. I mean, I feel like very inspired thinking about all the different barriers, and actually how to move forward too. I appreciate everyone's sharing of personal stories, professional stories, things that we've seen and observed. And I'm just trying to think okay, so what can we do? And I think we could spend the rest of the day kind of talking more about these inspiration points that we have, and how can we actually build community within us. Because I know, just looking at the attendee list, that many of us are all from different parts of the Bay Area too. So I think that's another way that we can build collaboration and community, and being together, we can we do move forward. I want to offer 1 or 2 questions from the audience, if there's anyone who'd like to pose a question.
Thank you. Very inspired to be here as an MSW graduate student in my final stages. So thank you for your presentation. As I'm working with the trans and queer community, and also being queer myself, first generation Hmong American, come from refugee and tribal communities, I'm wondering for you all, how do you access and include the API LGBTQ community within your scope of work? The LGBTQ community itself has a high rate of suicide, and so does the Asian American population, so I'm just curious. Thank you.
So this is something that we're actually really excited about doing is there are at least 2 of our staff members at CERI who identify as queer, and 4 of our interns that are MSW identify as queer. And so it's something that we are on the forefront of, and I know that it's a difficult situation in our community because like the taboos of mental health in the AAPI community, there's also taboo around queerness, right? And so these are conversations that are opening up right now. We're actually going to be launching a queer youth group. So we're very, very excited about that because we do recognize that there is this need in our community. And again, it goes to funding and resources, right? So the more funding and the more resources that we get, the more we can address these issues in our community, because it's not that it's not there. It's very much there, but there's nothing to address it, right? And so we fortunately have in place a really awesome queer employee who is, you know, very open with his queerness, and the community has welcomed him with open arms, and so he has launched this forward.
I'd like to also add in a plug. If the clinic or agency that you're working with doesn't have a diversity, equity, and inclusion committee, go ahead and lead it and be the one that starts it off. So I think inclusion is probably the best thing that we can do on our level in terms of being able to promote more awareness to it and see where our gaps are and how to better promote that. And I think I also want to apologize, like normalizing too and identifying myself as she, her, hers, and making pronouns the norm in introductions, I think is also like a start. And I think it's getting there. It's been picking up a little bit more too.
And so first, I just want to say thank you for the question. You know, with being an AAPI identified individual and also as a queer person, there is a lot of additional stressors, especially when you think about dating or relationships, right? So thank you for that question. And right now, I am running an Asian American community support group, and I do have a few days where we do talk about, you know, what it is to be AAPI identified and also an LGBTQ plus identified individual as well. So I also know that Dr. Miner, who is our director of internship training, he also has built up a team of different of our colleagues that are also, yeah. So yeah, I think, yeah, we're all taking kind of steps to really kind of acknowledge that.
At our school, we have a queer support group, but it's not specifically to AAPI. But I've had students, and I have session individually to talk about their identity, and that's been very healing, but there is, it's very complicated as they have not shared that with their family, but this is sort of like where the start is. Yeah, but I like that we can be able to continue that conversations in a setting that is intersectional, right?
Thank you.
Hi everyone, I'll try to make this quick so we can all get to lunch, but what can advocacy and capacity building organizations do to support this work? I know we talked about advocating for increased resources, funding, personnel, but what else can organizations that are not providing services or direct services, how can we be a part of this?
Thank you for your work in advocacy. I think that's like the heart of community as well, because you're representing them. And I think in terms of normalizing and reducing that stigma with mental health and knowing the resources of where to send them, because if they trust you more and you're the starting point, I think that's probably a good lead-in, and hopefully you can build more partnering with the different mental health facilities that are in the area to be able to pitch it and frame it better, or give them feedback of like, we're hearing this from the community and we just want to know what you guys are doing about it, and what ways we can promote that for you. I think that type of partnering is really helpful.
I know you already know the answer to this because we work with you.
No, I'm really asking for more.
I don't think you're asking me, but honestly, it's going into the communities and bringing the communities together, right? Because separated, we are weaker, but if we come together and we lean on our resources and lean on, the establishments that are already there, and then we'll be better able to provide for the community, right? So, like I mentioned at CERI, and I know they do at KCCEB, is, we have many different ethnic groups that we bring together, and and we do it over music, and we do it over food, and we incorporate all these other aspects of being a person, right? Not just the mental health aspect of it, not just the community aspect of it, but just overall as a person, right?
Thank you so much. I want to give another round of applause for